Hello there, and welcome to our first training of 2026. We'll be covering neurodiversity, affirming care with a specific emphasis on autism. We're going to start with our mission and vision statement. Our mission is to support families by matching them with exceptional nannies that demonstrate a commitment to education, professionalism, and community. And our vision is to become the exclusive resource for area families by providing trained child care professionals that deliver the highest level of customized child care and family support. Our mission is our best every day in every way. We'll be walking along the path on your screen today as we go through this training. These will be the things that we cover, the subject matters that we are visiting, with the hopes that we end with a heightened enlightenment about the subject by the end of our session today. We did an exercise with our in-person um, class that had to do with really the lens by which we view autism and more specifically autistic traits. And so we had a group of wonderful volunteers who came up. They behaved in certain ways that were described to them on a little piece of paper. And then we described them. We described them as a 36-year-old woman at a doctor's office appointment, as a adult woman at the park, as an adult woman in an airport, as an adult woman walking through Target, as an adult woman being approached by another individual. And when we looked at those behaviors in relation to the age and stage of the person, we all perceived, and the class perceived, that those behaviors were weird. They were out of turn. They were not socialized. They were not appropriate for the environment. When we recategorize those same behaviors through the lens of an 18-month-old who's been approached by a stranger, a 2-year-old that's in a waiting room, a doctor's office waiting room, a 13-month-old, walking through the airport, a 9-month-old toddling over to a swing set for the first time, then suddenly these behaviors and these proclivities became normalized, right? We saw them through the lens of that age and stage, and that was absolutely appropriate for that age and stage and no longer considered weird or unsocialized and things like that. And what it helped us to realize is that oftentimes we're viewing autism as an intellectual disorder, which it is not. Inherently, it is not. Inherently, it is more of a social disorder. These individuals are not aligning with social norms that we tend to digest, and they become intrinsic to us as we get older. And so if we look at it through the lens of an individual for whom they never were taught or developed to care about what was appropriate, what made other people feel good, what made other people feel normal in an environment, then we look at it differently. Any of our toddlers will run like they're an airplane. Any of our toddlers will spin in a circle. Any one of our toddlers would stare at an individual while they're talking to them and look them up and down without cracking a smile. Any of our toddlers will ignore spatial norms and be all up in your face, all of these things. And so when we look at it through that lens, it changes the way we perceive those interactions. And hopefully it inspires in us more empathy and more compassion and more understanding. We're going to start with just the way we look at this. We want to shift out of this pathology model, which we find a lot of adults in. So a pathology model sees autism, or really any form of neurodivergence, as a medical disorder, as a deficit, as something that needs to be fixed, cured, or normalized. And we really want to move into a neurodivergent model, or a way of thinking that states that this child's brain works differently and our environment needs to accommodate that difference. It really is more of a night and day difference. When we're thinking through the lens of pathology, we feel like there is a normal brain. So there is a typical brain. And so anything outside of that is abnormal. Anything outside of that, any deviations from that are medical dysfunctions and deficits. And so then when we're looking at through that medical lens and through that disorder lens, then we feel like we need to cure, heal, fix, or suppress those traits, which often leads to poor mental health outcomes because we're ignoring the root causes of that distress. We want to switch to the lens where we understand that all of our brains are different, and there are natural variations in our brains, just like we have variations in our humanity, from ethnicity to gender and more. And so we want to focus on our strengths, supporting, accommodating, dismantling different systems that are built for non-divergent brains, and really work to create an inclusive environment where people can thrive as they are. When we do this, we're able to more positively and succinctly preserve the child's dignity and self-worth. We can build on their strengths rather than relying on their deficits. It creates safer and more trusting relationships, and it really reduces stress and anxiety for both you and the child. It's a very nerve-wracking thing to have this mantle on you that you're coming into a home to fix a child, or you need to fix this behavior. Instead of coming into a home realizing that you want to find their strengths, you want to find the points of agreement and the things that you can do together and build on that relationship, that trust, that love, and that rapport. With regards to individuals who have been diagnosed with autism spectrum disorder, there are a few houses of therapy, if you want to call them. So there's behavioral, there's relationship-based, and then there's cognitive behavioral therapy, which is more like talk therapy. A note on talk therapy, just by the name, it is necessary that that individual be at an age and stage where they can both communicate and understand communication in order for it to work properly. With regards to behavioral therapy, there are applied behavior analysis, which is ABA, and it has different components within that. There's the picture exchange communication system, and even social skills training can fall up under applied behavior analysis. With regards to relationship-based therapies, there are floor time, which often you see in occupational therapy, even in speech therapy, and then there's parent-child interaction therapy. We're going to take a moment to focus in on applied behavior analysis, or ABA. There can be both positive and strongly negative feelings with regards to ABA, depending on your various experience, your parents' experiences, what they've heard about it, and things like that. And so we're going to take a moment to watch a short video that describes to us or informs us as to what ABA is and how it works.
Most often, parents already know that their child has autism. They're just waiting for an expert to sit down with them and formally diagnose it. There are times where a parent doesn't know that's going on and comes into the appointment unaware of what it's called.
Now we just have one diagnosis called autism spectrum disorder. Previously, it was broken up into succinct categories, and the categories were to help people understand different levels and different functioning levels of kids and persons with autism. Now it's all one disorder, and then we talk about different severity levels and functioning levels.
Autism is sometimes the A word that you don't want to hear it because you think it's going to be terrible, but autism is a spectrum, and there are children that have just a little bit of autism and who are in the mild range.
So a low functioning person on the spectrum would have intense behaviors that are impeding their ability to be independent in their life, little to no communication skills, unable to interact with other people and their environment without additional supports. Then you're going to have the higher functioning level spectrum. So in the past, it used to be called Asperger's disorder. People who have more of the stereotypic behaviors, repetitive interests, but their communication skills are there. They can communicate with other people. They can interact with others, but they still have some challenges and some barriers in those areas.
So difficulty with socializing with other kids, repetitive behaviors, such as toe walking, rocking, spinning. Those are the classic signs. The kids who are classically autism, you can almost diagnose right in the waiting room as soon as you greet them. They're fairly obvious and pediatricians are generally good at identifying those.
If they're a young child, some of the things that you want to look for are a lack of eye contact, lack of being able to engage in pretend play. So, for example, if you have a toddler and they're not interacting with baby dolls, they're not really using them to try to play, pretend to rock them or put them to bed. Another one would be social interaction. So oftentimes they prefer to be alone as opposed to be with other people. They don't start interacting with other kids. We call that parallel play, moving to more of an interactive play. They prefer to just continue to stay solitary.
Many kids with autism spectrum disorder have these heightened sensitivities to things tactile, things auditory, things olfactory and thermal. And as a result of that, they often recoil from situations and develop an intolerance for being in certain places and in certain environments. And the reason many of these kids have food-related issues is because of sensitivities that they have from an oral standpoint. They can't tolerate various textures in their mouth. They can't tolerate the smell of food or even the taste of food, for example. So those would all be some early indicators.
I think parents are afraid of the label of autism sometimes and afraid that this is going to change the course of their child's life. And really, I've had no one come back and say they wish they hadn't labeled their child autism, because in beginning to accept a diagnosis of autism starts the therapy for it. So it really opens up their world. It doesn't close it down.
The origins of ABA therapy harken back to the research of a groundbreaking psychologist by the name of B.F. Skinner. Dr. Skinner believed that behavior is changeable through positive reinforcement. Skinner found through his research that we all learn through the consequences of behavior. Behavior that is reinforced tends to rewire us and becomes our default behavior. He also found that behavior that is not reinforced will dissipate over time. Skinner's research is commonly seen in every one of our lives. As children, we learn to walk, talk, and avoid picking up hot things through repetitive training from our parents or loved ones. We learn most of our basic life skills through repetitive reinforcement. Reinforcers are essentially the outcomes of the rewards or consequences from our own behaviors. For example, rewarding a child for cleaning his room with money is a positive reinforcer. Cheering a child as she takes her first steps conveys to the child that the awkwardness of her first steps is worth the risk. ABA therapy simply expands this training in intensive ways until each child struggling with autism reaches new milestones and develops the habits he will need to live a full life as an adult.
ABA therapy is changing behavior by looking at what is reinforcing the behavior. So things that happen after a behavior occurs, where you can either expect that behavior to continue or expect that behavior to stop. And we look at the principles of learning in how we can change that behavior. So can we set up specific environmental situations, we call those antecedents, to ascertain a specific behavior? And then if the behavior happens that we want, how do we reinforce it so that we can expect that behavior to occur again in the future?
They have the way to help kids with autism down to a fine science that has little tiny goals that get added together to take a child from not being able to interact with other kids, being focused on their own internal world, into kids that can tolerate other kids, can be at school, can follow circle time, can answer questions for you, can get their needs met, can communicate. And that doesn't come from broad sweeping goals. It comes from this daily battle with these kids with tiny little goals.
Let's say we were trying to teach a child colors, and we've got some different objects out for them, and we're trying to teach them which one is the red object. And they just keep picking the yellow one over and over. So there's different principles of behavior. There's different learning strategies that we may use where we elicit the behavior that we're looking for, elicit the response that we're looking for. So we may move the red apple a little bit closer to them. That would be one type of prompt that we could use. And then when they pick the red apple, that's the red object that we were looking for, then we would give them some kind of reinforcer. It could be praise, it could be a high five, it could be something that they like, an edible item, it could be a toy for them to play with, something to let them know that the behavior that they just had, or the response that they just gave us, is what we were looking for, and that's a good thing. And then we would expect, based on that principle of reinforcement, that the next time that we ask them the same question, which is the red object, that they would be able to give us the correct answer.
So they're going to first be able to point to a choice between two objects, and they're going to be able to point between two pictures of what they desire. Then they're going to be able to say one of the words, and they're going to be able to request one of the words. And that process takes weeks to develop, but if they can slowly work at it, they'll get the child there. So at home, parents can be frustrated for years that they can't understand what their kid wants. They can't communicate with their child, and they don't have the time and the expertise to know what are the little steps that their kid needs to make to get there. ABA therapists know that and have the time, because it is one-on-one therapy at such an intense level. They get the child to where they need to be, which seemed impossible before ABA existed.
It doesn't matter, whether an individual has a physical disability or a cognitive disability, that they're not diminished in terms of value from anybody else. And I think that just becomes something so critical to keep in mind daily as you're interacting with individuals, is the preciousness and the beauty of a life, and just communicating that value to them in every possible way, and communicating your understanding of that value to your community is just critically important.
Right. So, with regards to ABA, there are a few kind of tracks you can take under that umbrella. So, there's the early intensive behavioral analysis. We're actually going to go to the other side of the screen and start with discrete trial training. This is really fundamental ABA, right? It's a structured, systemic approach that breaks down desired behaviors into small steps. Data collection is a huge component of this, and they track it and move forward like that. Early intensive behavioral analysis is a very intensive form of DTT, right? So it's usually 20 to 40 hours per week. So, I mean, like a full-time job for 2 to 3 years. And it's designed for children who are 4 years and younger. There's a lighter version of that, the Early Start Denver model. It's designed for children who are 18 months to 4 years old. This method focuses on increasing the child's motivation by following their lead during play, offering choices, and providing more natural reinforcement. Pivotal response training is also a more naturalistic play-based approach that builds on the child's initiative and their interests. It's particularly helpful in teaching communication, language, play, and social skills. And then there's social skills training, which also happens under ABA, which is teaching positive social behaviors and pro-social problem-solving skills. So helping them with conversation, perspective taking, emotional regulation, turn taking, so forth and so on. So we're going to watch some short videos, just a couple minutes each, and then we're going to come back to see which of these do we feel like is happening in that particular session.
Oh, way to go. Yep, and you can sit on the chair. Up the top here. Beautiful. Give me that hand. Here we go. Round and round the garden like a teddy bear. One step, two step. Tickle Daniel everywhere. You are such a ticklish guy. What's that? Oh, do you see your teddy? Oh, you do too. Let's get him. Oh, we can have a quick kiss. Come on, Teddy. Kiss. Okay, what we're going to do with Teddy now, let's put him up here so he can watch, because it's time to play the popcorn game. Okay, but uh-oh, we don't have all the pieces. So I need you to tell me what we need to get so we can play. Nice sitting, Daniel. Very good. What do we need to get? The lid. What's that? Lid. Get the lid. Okay. I like your sitting. Here we go. The big lid. Oh, the big lid. Silly me. Of course. Here's the big lid. Great thinking, Daniel. What else do we need? Popcorn. Popcorn. Okay, you stay in your chair. I'll get the popcorn. I've got the popcorn. Put the lid. Put it in. Okay, here we go. Ta-da-da. Nice staying in your chair, buddy. What else do we need? Oh, it's we need a cup. Okay. This one? Yeah. You want that one? Okay, there you go. And I'll get the red cup. Here we go. Let's turn it on. That one. Two, your turn. Oh, can you get it? Oh, good try. All right, well done.
All right, so when we're looking at that, what do you feel like may be going on there? EIBA, ESDM, pivotal response training, discrete trial training, social skills training. What are your thoughts? When we discussed it in our live session, we leaned toward the ESDM model or the pivotal response training. It was both more naturalistic, very play-based, not as rigid. And when we look in a few moments to the DTT, you'll see there's a really, really distinct difference in kind of how they go about it in that way. And so we felt like these may have aligned a little bit more with that. Let's see what's happening here.
A child to request or mand. Request or mands are typically the first verbal operant acquired by children. Learning to request can include anything from a food item like a cookie, a toy, or even a preferred activity. By learning to request, children can decrease disruptive behaviors as they will have functional modes of communication to gain access to their wants and needs in their environment. Cookie. 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 Oh, you did. You got a whole one because you said cookie all by yourself. Nice asking for cookie. High five. Good job, buddy. The instructor begins by delivering the reinforcer with model for pairing trials. The instructor piques the child's interest by holding the cookie where the child can see it, but it's just out of reach. The key to success is speaker motivation. The instructor uses a full prompt with a 0-second time delay. Cookie. By avoiding other words, the child is more likely to only repeat the word cookie. Beginning with a full prompt prevents the child from making an error and becoming frustrated. The instructor provides immediate positive reinforcement following the request. The instructor immediately repeats the exercise, providing less assistance or a faded prompt. Notice that the instructor does not say, "What do you want?" Teaching a child to only respond to phrases such as "what do you want" could lower spontaneous requesting in the future, as a child could become dependent on waiting for someone to ask them what they want before making a request. Each time the child was able to request the cookie with less pushing than they were in the previous time. Dude, you got a whole one because you said cookie. When delivering reinforcement during man training, avoid unnecessary words like "good job." Using just the name of the reinforcer itself will help the child to pair the word cookie with the actual cookie when making later requests. Select the response form that the child will use. Remember, requests can come in many different forms. It can include pointing, signing for an item, or a picture exchange. Select the response form the child will be most successful with and therefore more likely to use. Teach when motivation is strong. Remember, practice makes perfect. Build motivation by manipulating the environment so the child will be more likely to mand, such as giving a piece of a cookie instead of the whole thing. Fade your prompts so that mands are spontaneous. It's important that the child also learns to ask for things that are out of sight. This can be taught by moving items from just out of reach to being placed on a shelf to being placed behind an item where only a part of the preferred item is shown and eventually faded to completely out of sight. It's important to avoid meeting the child's needs before they have to ask for items and activities, such as asking "what do you want?" or providing free access to the items in the child's environment. These steps will help increase the likelihood that the child will request spontaneously. Once a child is requesting a single item, additional items can be taught. It is important to stick to single word request until the child's able to request a large amount of preferred items and activities, such as 20 to 30 different items, before multiple word requests are going to be required. Using sentences to request, such as, I want cookie, should be delayed until the child has a large enough repertoire of single word requests to have his or her needs met. Use database decision making. Collecting data will track the level of prompting required for each target, as well as the total number of targets the child has acquired.
All right. So that was some social skills training, but I really want to kind of circle back to what that speaker talked about. Requesting or manding, so commanding, are one of the first things our children do after they learn their first words. So mom, daddy, ball, whatever their first words are going to be. Typically, right after that comes words that fall into this category, right? Up, please, more, cup, doll, like whatever that is, these requests are the next form or the next category of words that a child learns. And so when we're dealing with humans for whom they fall in that ASD category, maybe they have not learned those things. And so there's a high degree of frustration that can come into play when you don't know how to get your needs met and you don't have a way to articulate or to communicate that, whether verbally or non-verbally, to a person who can help you meet those needs. And so providing a pathway for them to be able to get what they need is going to be very beneficial in reducing anxieties and frustrations. How can this play into our typically or non-neurodivergent population? The same way, when we're dealing with our babies and our toddlers after they've learned their first word, teaching them these words that can help them to get the things that they most often need will help to reduce frustration as they're still learning language. As you can see, oftentimes we're not doing that. When we're teaching toddlers and infants and we're talking to them, we're using long sentences and things like that. But when we get into this stage where our child is starting to say mama and daddy, and they're saying other words, and now you're trying to teach them to ask for the cup, then we're just going to say, would you like a cup? Would you like some water? And we just say water, water. And we do these things so that they can grasp hold to the word that is going to, and the command, the request that is going to get them the response. And when we're lining these things up into a long sentence or a long request or a long phrase, it is harder for them and it increases the time it takes for them to learn that. And so these things have dual applications. But as you can see in SST, it is very familial. It's very low pressure. But she is watching to see, and she is not adding things in there. It is just cookie. Just cookie. There's no other words. There's nothing else to distract from the main thing that she is prompting him to say so that he can get to that end result faster and more succinctly.
I have something to show you. Go sit on your chair. I know you were under the table. I'm going to ask you some questions and then we can play a new game or we can play chase. It's up to you. I love chase too, but first I have some questions. You ready? You are going to do it. Oh, they're stuck in the box. I bet you know what this is. You ready? Nope. We're not going to be able to play until we're all done. Come have a seat. Hey, look. Let's do 5 things. 1, 2, 3, 4, 5. Oh, then we'll play chase. Ouch. I'm sorry. Are you okay? So look. 1, 2, 3, 4, and 5. Leave them right here. When you get all 5, we will go play chase. Okay? You ready? I'm gonna ask you questions. Fix your chair. Have a seat. Okay. Here's one. What is this? Cookies. Cookies. What do you do with cookies? Eat them. Chop, 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 chop. Hey, what kind of cookies are these? Chocolate. Chocolate. Here's something else you can eat. What is this? Apple. Apple. That's right. Okay, I have a few more. Let's see. Nice job answering the questions about the foods. Next one. What is that? It's hot. It is. What would you call this? A car. Hey, are these the same? Yeah. They are. And is this the same? No, what is this? You're right. Okay, let's give you number 2. Thank you. 3 more. Fix your chair, or you can stand, but be at the table. Okay, let's see. These are really easy and fast. Okay? I'm gonna ask you, what color? Pink. Dark pink. I can't trick you. There's the 3rd one. Okay. Gonna ask you 2 more kinds of things. You ready? Then we'll play chase. Where does a fish live? In the sea. In the sea. Good answer. And where does a zebra live? At the zoo. You might see him at the zoo. Nice job. Okay, last thing, no cards. I just want you to do what I do. Can you do this? Good. You want to splat it? Flat. Can you do this? Try again. Can you do this? Good. Can you do this? All right. I want you to splat. I want you to do what I do. Can you do this? Good job. Now touch your nose. No. Touch your head. Touch your ears. Touch your belly. Where's your belly? Touch your belly. Good. Okay. Hey. That's my spider. What's this? No. Nose. Last one. You got all 5. You ready for chase? Okay, I'm gonna get you. Animal. Is that? I have something to show you.
All right. So when we're looking at that, I want you to, I hope with each of these scenarios that you're taking notes on how they are interacting with the children. One of the things that you should be able to see is how quickly they are reinforcing or responding to the child to keep them engaged. In the previous video we watched where the little boy was getting the popcorn thing, how she kept touching his legs to help him remain seated on the chair, but she did not take the focus off the main thing. She did not allow her reinforcement of him sitting on the chair to distract from the thing that he was supposed to be doing and the process that he was learning. With this same thing, how the instructor kept her, seated, and gave those minor corrections without allowing that to overtake what was the main thing, and how quickly and the ways that she reinforced her in there. As you can see, she's learning a lot of things. They're building her vocabulary. So when you're looking at these models or these pathways, which one of these do you feel like best aligns or could align with what we just saw in that previous video? After discussion with our live group, we came to the conclusion that we felt like this was a EIBA, that the child was in ABA, but clearly had been in intensive treatment since she was under 4, to increase the probability of her aligning with social expectations, having a larger vocabulary, so forth and so on. So right now we're going to look at what is the discrete trial. So what you've been looking at are like the softer versions of this, the more play-based versions of this. What we're going to look at right now is the discrete trial. This is really what ABA is about for our children who may be higher, lower functioning on the ASD spectrum. These are how they are taught certain things, certain prompts, and we want to look at that process. Take very close attention. Please pay attention and take notes on how the individual is interacting with them, how they are engaging them, what is the time lapse between their words and an action, and so forth and so on. Okay.
First video in the series will provide you with an overview of one of the basic tools used in intensive behavioral interventions, the discrete trial. The discrete trial is made up of several distinct components.
Nice sitting.
It begins with the SD, or discriminative stimulus.
Do this.
This is the instruction given by the therapist to the child. Next, the therapist either waits for the child to respond or provides some help in the form of a prompt if needed. Finally, once the child has responded, the child is given reinforcement, a reward for a correct response, or a correction for an incorrect response.
Let's try it again. Do this. All right, good trying. I like how hard you're working.
You have just witnessed one discrete trial. After a brief pause, the therapist then begins another complete discrete trial. A discrete trial is made up of the following three components: an SD in the form of an instruction by the therapist to the child, a response from the child or a prompt from the therapist, and finally, reinforcement or correction if necessary from the therapist. Let's now examine each of these three components in detail, starting with the SD. Though generally an oral instruction, an SD can also be nonverbal, such as a picture, a toy like Mr. Potato Head placed on a table, or the sight of a swing.
Super!
A good SD must follow several guidelines in order to be effective. First, all SDs should be clear and consistent. They should be free of extraneous information. And finally, they should be delivered in a voice slightly louder than a normal speaking tone. Now we will demonstrate what a good SD looks and sounds like.
Do this. Way to go! Wonderful! Touch half. Oh, that was so neat! Match.
Now we will demonstrate what a poor SD looks and sounds like.
Touch my nose. Put one up for me. Where's my nose? That's right. Find my nose. Ooh, super, Corey.
We will play the good SD once again. Take note that the therapist speaks clearly and consistently, uses a short, concise instruction without extraneous information, and speaks slightly louder than he or she normally would.
Do this. Way to go! Wonderful! Touch half. Oh, that's so neat! Do this. Good girl. Do this. Do this. Marvelous. Do this. Do this. That's right, Corey. Do this. Do this. Wonderful. Do this. Do this. Hooray!
Now that we have covered the basics of delivering a good SD, we will move on to the next step in discrete trials: prompting or waiting for a response. When first beginning to teach a new task, the therapist should immediately prompt after giving the SD.
1.
A prompt is some form of assistance to help ensure that the child responds correctly. This teaches the child how he or she should respond to the SD. Indeed, any time a therapist is not certain that the child is capable of responding correctly to an SD independently, the therapist should prompt immediately.
I hope you all noticed in there that the prompt, and for all intents and purposes for that video, were the blocks in front of the number 1, right? So when she said 1, the assistant to the prompt was the fact that she put blocks in front of the card that had 1.
The next step is the gradual removal of the prompt. This occurs once the therapist believes the skill being taught has been learned, and once he or she is sure that the prompt is no longer needed. When removing a prompt, the therapist must be careful to avoid inadvertently giving a delayed prompt. This situation can occur when the therapist thinks the child knows the correct response.
What does this say?
The therapist gives an SD, pauses and waits for the child to respond, realizes that the child is not going to respond or is responding incorrectly, and jumps in with a prompt. The therapist must decide before delivering an SD whether or not to prompt, and if so, to deliver the prompt immediately after the SD. We will now move on to the third and final component of a discrete trial, reinforcement or correction. Once an SD has been given, the child responds in one of two ways. Either the child responds correctly and reinforcement is delivered, or the child responds incorrectly and a corrective procedure is applied. We will begin with reinforcement, which is sometimes called a reward. When providing reinforcement to a child, there are several key points to keep in mind in order to maximize its effectiveness. First, reinforcement must immediately follow a correct response. Reinforcement is given whether the child responds independently or with the help of a prompt. The second principle of reinforcement is that it should be enthusiastic and involved. If you are excited and enthusiastic when delivering the reward, the child will enjoy the reinforcement more, and that will lead to better learning. Lastly, reinforcement should be varied. If the same stale rewards are used all the time, they will lose their effectiveness. Remember, effective reinforcement is best achieved if given immediately after a correct response by the child, given in an enthusiastic and involved manner, and if the reward is varied. There is one eventuality that we have not yet covered. What happens if the therapist delivers an SD and the child gives an incorrect response? There are two general approaches to dealing with incorrect responses. One which uses an informational no, and one which does not. The traditional approach is to use an informational no. When the child gives the incorrect response, instead of giving a reward, the therapist responds by saying no in a neutral tone of voice.
Where does grandma work?
He works in the house.
No. Where does grandma work? Say library.
Library.
Let's watch that again. The no is not meant to be aversive or punishing. It is simply meant to provide the neutral information that the response was incorrect and will not be rewarded.
Where does grandma work?
He works in the house.
No. Where does grandma work? Say library.
Library.
Now you get stubborn!
The therapist then goes on to give the same SD again, but on that next trial, the therapist prompts the child to ensure that the child gets the response correct. Another approach is to leave out the informational no. With this approach, if the child gives an incorrect response, the therapist pauses a moment without giving reinforcement, but does not say no.
Thumbs up.
The therapist then begins another discrete trial and prompts immediately after the SD is delivered. This is to ensure that the child gets the response correct. Let's watch the errorless learning correction one more time.
Thumbs up. Thumbs up.
We have now reviewed the three components of the discrete trial: the SD itself, the prompt or waiting for a response, and reinforcement or correction. The remaining videos in this series will explore the...
All right. So as you saw, we were covering, that video was a very in-depth look at the DTT, which is what typical ABA is looking like. So when you imagine a child going in for ABA therapy, and not in an intensive, just typical therapy, that's a lot of what it will entail. Now we're going to move on to positive reinforcement. As you can see with each of those interactions, they are positively reinforcing what they want to happen. I actually do want to circle back really quick. The informational no is something that has broad applications. Oftentimes when we're telling children no, we have like some feelings behind it. Our no has a little bit of edge. It has a little bit of stank on it. It has some emotions behind it. And we could all take we could all benefit from using more of an informational no. A child is going this way, and we just immediately are saying no, and then we show them where to go, and then we positively affirm them going in the right direction. But saying no as a source of information versus saying no as a consequence, as a negative consequence, as a, I don't know, an obstacle to whatever, it's meant to be a source of information. Just like, come, you're doing it, you've got it, come on, come on. We are consistently affirming or giving information that lets them know that they are on the right path. No is just letting them know that they're not on the right path. And we can do so without so much oomph sometimes, without so much emotion, so that the child doesn't have to react and see no as something that they have to react so negatively to if we don't attach so many negative emotions to the no when we present it. Okay? Positive reinforcement. There is no term I hear more when I am interviewing nannies or our staff is interviewing nannies and asking them their discipline style than positive reinforcement. I use positive reinforcement. I would submit to you that our version of positive reinforcement is not positive reinforcement. It is positive well wishes. It is positive affirmation, but it is not positive reinforcement because positive reinforcement is an actual school of thought. It has a rhyme and a reason. It has a way that it goes, and we are not usually positively reinforcing in the way that we think we are. So let's walk through that. Positive reinforcement refers to the presentation of a stimulus. So that's what you saw in those videos. In the DTT, that ST is a stimulus, right? It presents the situation, the child then behaves or responds, and then we reinforce that behavior, the behavior that we want to see. So there's a stimulus, and then contingent on behavior, um, that increases the probability of behavior recurring in the future under similar conditions. The reinforcer is a tangible object or event that is delivered following the occurrence of a behavior that would increase the probability that the behavior would occur under similar conditions. The characteristics of positive reinforcement are as such. They are immediate. Oftentimes, you may not be getting the connection that for that child between what you're enforcing and the behavior because it's not immediate enough. As you saw in that DTT video, the child says it, it's boom, something is happening. Somebody is tickling them, somebody's giving them something, they're knocking off something. There is a very quick and direct correlation between that action and this result. The size and the amount of the reinforcement must be congruent with the size and the difficulty of the task that we're asking them to do. The quality of the reinforcement has to be highly preferred by the learner. When we polled our team the other night at our in-person training about what they use for positive reinforcement, 90% of what they're using for positive reinforcement are words. Good job, buddy. Great job. Way to go. So proud of you. Fantastic. Wonderful. Look at you. Right? Maybe a high five, maybe a hug, maybe a juice. But the majority of it is that the quality of the the reinforcement has to be highly preferred by the learner, right? And it cannot just be the one thing. As you saw in those videos, they're not always just using one thing. They have a bag of things, a deep vault of things that they are using to reinforce this behavior. So they're knocking off the blocks, they're getting a tickle, they're doing a pop toy, they're having this, they're getting a little vibrating thing. There's so many things that are positively reinforcing this behavior, and those things must be highly preferred by the learner, which is our part, is for us to learn what our children prefer and highly prefer. Then contingency, that thing that they highly prefer has to be delivered only when the behavior is observed. The thing that we're trying to positively reinforce, when it is observed, then we do it. It is contingent on that. If you give it before it is produced, you are not positively reinforcing the behavior. And then it has to be something that they don't always have access to. So if they can get Cheetos any day of the week and then you're using Cheetos to positively reinforce, it is not going to have the same quality and it's not going to be as effective as you would like it to be because the quality of a reinforcement is that they have limited access to it. So I had the pleasure of working with so many children, and oftentimes when I'm dealing with children for whom positive reinforcement is their track, I bring kind of a nanny bag, and in that nanny bag I change it every day or so. with new things in there that they can play with. But it is always contingent. So when I come in, if the thing that I am reinforcing is that we do dinner and bath time and they're always fighting bath time, then when I come in and they're like, oh my gosh, Miss Erica, can I see what's in your bag tonight? I was like, yeah, we can only look at it after we eat dinner and after we take our bath. Then we can look in the bag and see what's in there and decide what we want to play with. But we can only do it after bath time. So all through the evening when they're asking for it, it is always contingent on the thing that I am looking to positively reinforce. We can look in the bag after that. Now, when they get into it, they love it. It's great. They're highly preferred. It's things that I have learned about them that they would be into. And then there's deprivation when they like it and I'm getting ready to leave. Can you leave this here till tomorrow? No, I cannot. It comes with Miss Erica and it will come back with me another time, right? Because it has to have limited access in order for it to continue to be highly preferred by the learner. When we look through the lens of these characteristics, I'm sure you, just like myself, when I was learning these things over these past years, learned that we're not really using positive reinforcement, right? We are using positive praise. But most of our reinforcement is not meeting these characteristics. Our great job buddies is not always immediate. It's not necessarily highly preferred by the learner. It's not always contingent, and it's not something that they have limited access to. So it does not meet the qualifications that are necessary for it to be a reinforcer of a positive behavior. In order for a stimulus to be considered a reinforcer, it must increase the probability that the behavior will occur again in the future under similar conditions. So what happens is there's the antecedent, which is what happens right before the behavior. So if I have a 18-month-old to 2-year-old that I am teaching to come when I call, right? So we go in the driveway or we're out in a protected area and I let them walk off and their name is James. So James starts walking and I say, James. James is the antecedent. It's what's going to happen right before I recall this behavior, right? So James, I call his name and he looks at me. And then I say, come. Not come to Miss Erica, come here. I say, come. And then immediately I go to James, I grab his little hand and I bring James to me. And then I give him the consequence. We have lots of hugs. We jump up and down. We blow the pinwheel. We get lots of tickles. And I say, great job listening, buddy. Great job coming. And then I let him go again. And then it happens again. The antecedent is that I call his name and I say, make eye contact. And then I say, come. So I do it again. I call his name, James. He turns, we make eye contact. I say, come. And then I go to him, I grab him again, I bring him to me, and then the consequence happens as a result of that behavior, right? And then we continue to reduce the prompt. So next time when I say James and I say come, maybe I don't get him. Maybe I just put my hand out and then he comes to me. We have a consequence, we positively reinforce it, we do something different, maybe we dance, maybe we get a sip of a great juice, and then we do this again until we get to the point where I can reduce the stimulus, right? And then I can just say come, whether he makes eye contact or not, and he automatically comes, right? Now, to be clear, as you can see on the bottom of your screen, a reward is not necessarily a reinforcer. It is only a reinforcer if it meets these requirements, if it's immediate and if it's highly preferred by the learner and if they don't always have access to it. Oftentimes, we may be giving rewards that are not highly preferred by the learner, right? So you say, hey, you can have a Skittle. And if they're like meh about Skittles, like they like it, it's sweet, but it's not their favorite thing, it is not a reinforcer. It does not, just because it is a reward, does not automatically assume that that is a positive reinforcer. In order for it to meet the qualifications of being a reinforcer, a positive reinforcement of said behavior, it has to be immediate, it has to be highly preferred by the learner, it has to be only delivered when the desirable behavior is observed, and it has to be something that they have limited access to. Our job and our goal as nannies and professional household staff is that we have a large array and variety of reinforcers that we can cycle through specific to the children that happen to be in front of us. Some children love olfactory things. Some love the things that they can smell. So they love smellies, taking new chapsticks and putting them on them that they can smell, smelling new spices, smelling new perfumes, like all those types of things. Some love things that they can touch, things that vibrate, things that are sticky, things that are hard, things that are soft, things that are itchy, things that are smooth, right? They love those things. Some love things that they can do. They want to jump, they want to dance, they want to tickle, they want to hug, they want to be thrown in the air. Some love things that they can eat. They they want candy, they want salty things, they want bread, they want avocado, they want whatever that is. Some want something they can drink, some want something that they can take with them, whatever. Maybe it's a game, maybe it's playing a PlayStation game, maybe it's doing a dance number, maybe it's watching a 2-minute video. Every one of us have an unending supply of reinforcers if we were to look for them, to learn our child, and then to apply those. They have to be varied, and a reward is not necessarily a reinforcer. Okay? So, positive reinforcement for all of those who come to bear that we believe in positive reinforcement. Positive reinforcement is when there is a behavior, an antecedent, then behavior is observed, and then there's a consequence that happens as a result of that behavior. And that consequence is something that we are reinforcing through something that they have a high degree of preference for, that is immediate, that is delivered only upon the receipt of that desirable behavior, and that learner has limited access to. The immediacy of the reinforcement is one of the things that increases the probability that the behavior will occur again in the future. Okay? Let's watch a short video on that.
In this video, we will define and give some examples of different types of reinforcers. We will explain why we use reinforcers and provide some key points on how to use them to maximize their effectiveness. A reinforcer is anything contingent on a behavior that increases the likelihood of a behavior recurring. Simply put, reinforcers are rewards that we use to signal to a child that he or she has responded correctly and to encourage the child to respond the same way again. Reinforcers provide motivation and essential feedback to the child and strengthen learned responses. There are an endless variety of ways that you can reinforce a child. Here is a list of a few options. The most basic type of reinforcer that you can use is food or drink. If you give a child a piece of a desired food or a sip of a favorite beverage after responding correctly to a task, the child will be more likely to respond the same way again. Food or drink can be excellent reinforcers, especially at the beginning of therapy when you are still determining what the child might find rewarding. Other reinforcers include favorite toys, physical touch, and activities such as tickles, bouncy knee rides, or hugs as rewards for correct responses. If the child enjoys these things, they can be wonderful reinforcers. Another useful reinforcer is task avoidance. Ending the task at hand can be very rewarding for many children. Removing the teaching materials from the table, throwing away quiz cards as they are finished, or allowing the child to get up and leave can be very potent reinforcers.
Do this.
Do this.
Do this.
That's right, Corey. Do this.
Do this.
Wonderful. Do this.
Do this.
Another important type of reinforcer is verbal praise. Verbal praise is a bit different from the reinforcers mentioned so far because most children with autism will likely be indifferent to verbal praise at first. However, verbal praise is very commonly used in our society today. Therefore, it is important to teach children with autism to learn how to enjoy it. To accomplish this, we must always include verbal praise with the other types of rewards that we use.
Touch shoe. Oh, way to go. I don't know how hard you're working. Good work. I've got more crackers.
By consistently pairing verbal praise with other rewards, such as food, toys, or physical touch, the children will slowly learn to enjoy it. The last types of reinforcers that we will discuss are counters and token systems. When counters or tokens are used, the child earns tokens or points that can be exchanged for rewards. Here is an example of a counter in which the child must earn all the pieces of a puzzle in order to get the end reward.
What do you want? Alrighty. Oh, why? Oh, why? Look, we're gonna get on the cars. Yeah. Then cookie. Yay. Shoes. Put it on. There, you got one. Wow. One more. Shoes. Yeah. Put it on for you. There it goes. Boink. Shoes. Wow. Do, 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 do. Here we go. Shoes. Boink, boink. I'll pull it out of this one. Shoes. Boink. You need one more, then you get cookie. Shoes. Here it goes. Boink. Look, you got all your cars. Time for cookie. Yummy.
Counters and tokens tend to be used when children are slightly more advanced in their treatment programs. They allow us to teach children to work for short periods of time without receiving a concrete reward. Many different kinds of counters can be generated, and we can vary the number of responses needed to get the end reward.
Clap hands.
Now that we have explained what reinforcers are, let's talk about why we use them.
There it goes.
One reason we use reinforcement is to provide feedback about the correctness of a response.
All right.
Because children with autism have difficulty processing language, we must rely on reinforcers to let children know when they have responded in the way that we want.
Box.
The second reason we use reinforcement is to motivate the child to learn. Our goal is to make therapy so reinforcing that the child looks forward to this time of day as the time of day when great things happen. There are several key points to keep in mind in order to maximize the effectiveness of reinforcement. If a child gives the correct response, we must deliver the reinforcement immediately. The therapist must be enthusiastic and involved, and the reinforcement must be varied. These components ensure that we reinforce the target behavior. The reinforcement must be immediate because if reinforcement is delayed, we might inadvertently reinforce something the child does after the target behavior.
Good job.
By reinforcing immediately, we let the child know clearly which response is correct. Reinforcement is also more effective if we involve ourselves in whatever type of reinforcement we are using. Make the play fun. For example, if we are giving a child a piece of food, instead of just placing it on the table for the child, we can fly it to the child like an airplane.
Chips. Oh, wow. That was great. Yummy. Do
This way,
puzzle.
we become reinforcers for the child.
Corey, which one? Awesome.
The last point is to ensure that reinforcement is varied. Varying reinforcement means two things. First, we must constantly change reinforcers. Second, we must vary the intensity of reinforcement depending on how the child responds. Constantly changing a reinforcer means that a reinforcer should not be used more than twice in a row before another reinforcer is substituted. If a child is given the same reinforcer repeatedly, the child will get bored with it and no longer find it rewarding. This is called satiation, and it can greatly slow down the progress of a child. Varying the intensity of reinforcement is called differential reinforcement. Differential reinforcement means that the child will receive a more preferred reward for better effort or a well-executed response. By saving the best reinforcers for the child's biggest efforts, we encourage the child to put forth a maximum effort. Now that we have defined reinforcers and talked about how to use them, we need to discuss how to develop new reinforcers. We must be constantly searching for new and effective reinforcers in order to vary them and avoid satiation. One way to develop new reinforcers is to observe what the child enjoys doing during free play. Favorite toys can be reserved for use in therapy or used as rewards after therapy. If the child likes television, he or she could earn tokens towards watching 5 minutes of television. Another way of finding new reinforcers is to modify a child's existing self-stimulatory behaviors. Gazing at a light, arm flapping, spinning, and lining things up in rows are all common self-stimulatory behaviors. It is often possible to modify these behaviors so that they are non-disruptive and more socially acceptable. For example, if a child likes to gaze at lights, you could teach the child to enjoy playing with a kaleidoscope and then use that toy as a reward. Finally, you can test for new reinforcers using a reinforcement survey. To do this, present the child with a choice of 2 potential reinforcers and keep track of which one the child chooses. Once you find a reinforcer that works to motivate the child, you should not allow the child to play with it outside of therapy. And within therapy, you should limit the time that the child has access to the reinforcer to about 10 to 20 seconds each time it is used. By reserving reinforcers for therapy, you increase the chances that the child will remain interested in them and motivated to learn. So far in this video, we have defined reinforcement and given some examples of different types of reinforcers. We explained why we use reinforcers and provided some examples of how to use them to maximize their effectiveness. We also discussed ways to develop reinforcers that are the most effective for each child. I hope that you have found today's training video useful, and I would like to wish you the best of luck.
All right. So hopefully we have some more insight into the things that we could be utilizing to increase engagement with our children. I think there's a lot more work that could be done on our child, not our children's side, but on our side to positively and correctly and accurately positively reinforce behaviors. I hope we all have a different understanding of what positive reinforcement really looks like and what it entails so that we can do the deep dive and the work necessary to be able to utilize it in its true form so that we can get the results that can actually occur when we do utilize it correctly. Now we're going to take a break and then we're going to come back and move into PCIT, Parent-Child Interaction Therapy.